So it's fairly well established that beta blockers are a good thing in patients who've had an MI, but there's a real reluctance to prescribe beta blockers in patients with COPD. And that's because COPD is an obstructive airways disease, but it's actually a fixed airway obstruction that people with COPD have. So in theory, and particularly if using cardioselective beta blockers, there shouldn't be any negative effect on airway function in this group. A large proportion of COPD patients, about a third of COPD patients, die of cardiovascular disease, and a large proportion of those deaths will be directly associated with having had an MI. So there really is a reason why they could be particularly beneficial in this subgroup of individuals. So we looked at two things. Firstly, we wanted to know if patients with COPD were being prescribed beta blockers when they had an MI. And secondly, did being prescribed a beta blocker have an effect in terms of reducing mortality?
In the UK, we're very fortunate to have the National Health Service that people are registered with. And so we can follow people over time in their care. And because of the increasing use of computers as the main basis for clinical records, we as researchers can use completely anonymised, confidential data to answer important questions. So using the CPRD, which is the Clinical Practice Research Data Link, which is a collection of primary care computerised medical records, linked to MyNap data, which is the Myocardial Ischemia National Audit Project data, we were able to look at this question with unprecedented power.
We initially started with a subset of patients from MyNap, and we identified patients who had their first MI within MyNap. And then by linking the MyNap data with CPRD, we were able to establish which of those patients also had COPD. And we identified just over 2,000 patients in that group. Because of the detail that's available in MyNap, we were then able to see whether or not these COPD patients were prescribed beta blockers at the time that they had their MI. And 586 patients were never prescribed a beta blocker throughout the study period. 244 of them were prescribed a beta blocker before they had their MI and continued on it at the time of their MI. And 233 of them were prescribed a beta blocker during their hospital admission for their MI. So we lost just over 1,000 patients from our initial data set in whom beta blockers were coded as being not applicable or contraindicated. It's very possible that some of the reasons people felt that those beta blockers were contraindicated was because of an underlying diagnosis of COPD, but we weren't able to establish that, and so we had to simply exclude that large subset of individuals from the analysis. We found that just over 38% of COPD patients were prescribed a beta blocker when they had their MI, or continued on their beta blocker once they'd had their MI. And when we looked back in the initial MyNap dataset at first MIs, not including the COPD patients, that number was over 80%. So quite clearly, COPD patients aren't being prescribed beta blockers when they have their MI. We found that the COPD patients who were prescribed beta blockers tended to be younger, they had fewer cardiovascular comorbidities, and they tended to be the infrequent exacerbators of COPD. And in our initial analysis, and when we adjusted for all of those factors, we found that there was a decrease in mortality in those COPD patients who were prescribed a beta blocker at the time of their MI compared to those who were never on a beta blocker, and also a reduction in mortality in those COPD patients who continued on their beta blocker at the time of MI compared to those who were never on a beta blocker.
I think the importance of these findings are clear, that patients with COPD who have had a myocardial infarction clearly need to be on a beta blocker, and we've shown clear benefits. As well as that, through my clinical career, I've seen a complete shift. If you take heart failure as an example, where in the old days we used to think beta blockers were completely contraindicated, and large trials have now shown there's a clear advantage and that they make people live longer. I think we're beginning to see that shift, possibly in COPD. We don't have the large trial data yet, but I suspect we're going to see a change over the coming years, that beta blockers are going to be used more and more in COPD, and we're going to see more and more benefits from them.